You need to look at what is needed and then provide, and then optimize the deployment, and then anticipate future needs. So these are the three things that are very critical in planning and management. We don't do very well with the aligning the workforce supply. That one is not being done at all. And then optimizing the workforce deployment too, we are not really doing too well on that, because I think that policy-wide there was a thinking that production will lead to equitable distribution, but that had not happened really. And there are a lot of reasons why it has not happened. So workforce planning and management is, we are ensuring that the right people with the right competencies are in the right place at the right time. But then there are a lot of challenges in the healthcare system because of the complexities that we have in the healthcare system, that we are managing different cadres of staff, different levels of specialization, and it's a complex situation. And planning approaches need to capture these complexities. The factors are many, and so the workforce planning and management need to look into all these. And I'll mention some of the complexities, and we see it in our system. The first complexity is the systemic delays. This is because you are training somebody for 6 years to come and function in the system. There's that complexity of how do you anticipate what will happen in 6 years' time for the person you are training. It's a complex thing. And then the numbers, how do you manage the thinking about the projection into the future? And then combinatorial complexities. We talked about the care pathways in health are many. Somebody can jump from a physician assistant, go to graduate entrance and become a medical officer. So, and it is complex, and specialties diversification makes it even more complex. So when you are planning, then you need to think about all these. And then the dynamic complexities also, attrition rates, the training program, transition, and all that. It makes it very complex to do health workforce planning. Then when you come to the training, you are looking at skill maintenance, adaptation to innovation, and meeting evolving needs. And those are the things that we need to occupy ourselves when we are looking at our health staff. And most of the time, it's not only the individual capacity that we are looking at, but then the organization. So we have various formats, the classroom training, online courses, college degrees, etc., that we use to train the health workforce. But then, one of the ways, there are a lot of challenges, but then you can find out that in our system, we try to address some of the challenges. The limited resources for training, so then you have scholarships, study leaves to try to address them. The geographical constraint, the distances. Now we are leveraging on technology to ensure that the person does not need to move. The person can do online courses. And then access to training, we decentralize the training, etc. So these are some of the ways. Then the next thing in the workforce development is the recruitment and retention. By and large, in the health sector, we really do not do really active recruitment in the sense of recruitment in human resource, because to do effective recruitment, you are looking to attract highly qualified candidates. But we are stuck with those who come. I mean, it's like we have trained them, we take them. I mean, so there's something really missing there. And going forward, those things I think will change. Employment retention focus. How do you ensure that they stay with you? Because then quality of care is very dependent on, trained staff who stay long enough with you. So the recruitment and retention strategies are very necessary so that we ensure that, because we are competing with global markets now. And we need to see how we can ensure that we retain our qualified staff, recruit them well, because a lot of the issues we are having is to do with the recruitment and then the retention strategies. Because you see, our focus had been on the production rather than how do you recruit and then retain them. So those are the issues that going forward we need to look at. So what are some of the challenges in health workforce deployment? There's shortages and maldistributions. So we find that certain specialties are missing. pathology, anesthesia, emergency medicine, and then some are overflowing. How do we manage that? And then the maldistribution that have been talked about. And then the adaptation to the changing landscape. A lot of things are changing. And how do we adapt to that? So health, the shortages, the uneven distribution, and we need targeted interventions for this. You see, you need policy that will target this issue critically to address the maldistribution especially, and then the shortages, which is really an artificial shortage. How do we create the fiscal space to take on? The problem has been that the government are continue to be the majority employer of health workers. How do we bring in the private sector into the space and leverage them to absorb some of these? And it needs very targeted intervention. Then the evolving healthcare, that the changes that are happening. AI is coming, machine learning is coming. How are we going to adapt our workforce to adapt to these? And a lot of work, when you look at the literature, a lot of work has gone on looking at the changing trends and how the health worker need to adapt. This is looking at the risk of technology and impact on skills in the health workforce. So this is something that dealing with our human resource, we need to look at that. The terrain is not going to be the same. And I talk about the effect of artificial intelligence, machine learning. It is probable that certain positions within the healthcare sector may be displaced. It will disappear. Because my mom was a stenographer secretary. Now there are no stenographer secretaries anymore. It's an extinct profession. The same way a lot of the branches of medicine will disappear because of AI and machine learning. Roles primarily involve any role that has a repetitive task, such as disease diagnosis, specific administrative duties like patient registration, can be automated through AI. And then medical education will now need to look at incorporating these technologies into the training and training the students in new skills that are needed, like communication, the soft skills, communication skills, teamwork, leadership. Because a lot of the things will be taken up by this machine learning, AI, etc. The factor that facilitates health workforce development are the strong leadership. A lot of decision need, and then effective health workforce policy, the incentive that need to be provided for retention, recruitment, and the maldistribution. You need to put incentive in place. A policy that will incentivize somebody being in a deprived area against somebody being, there's something that we cannot run away from, because the thinking that numbers will change distribution will not happen. There should be an intentional policy around distribution, and you can't run away from incentives when you do that. And then continuous education is also very critical. So let's look at the uses of technology, and I think I've mentioned them. So let me move on to the private involvement, which is very critical. What is the role of the private sector? The World Health Organization, I think my colleague, the director, PPME, alluded to it, that you see, the way to achieve UAC, the government cannot do it alone because of the position and the access that people have. You need to involve the private sector to do. So the World Health Organization, in its resolution, engaging the private health service delivery sector through governance in a mixed health system, acknowledges. And there's something that is there that we need to really look at. So the private sector plays a large role in health in Africa. 35% of our outpatient is delivered by private for-profit sector. And then 17% is delivered by informal private providers like the pharmacy, etc. And this is work that was done by this group. And then in the same, there's this other literature also that looks at it. Okorafor, they said public sector, they looked at 4,000 in Africa. 4,061 health training institutions who are doing training. Public sector is 56%, private for profit is 34%, private not for profit is 10%. So that quite a lot of them are involved, especially in the pre-service training of health workers. And Ghana's private sector contributes to education of health professionals, nurses, midwives. But then you find out this is what has resulted in the glut that we are seeing, because the policy environment was facilitative for the private sector to produce, and they have produced. And now we have a glut of almost like 4-year batches of nurses and midwives, pharmacists, almost like 7-year batches of pharmacy, or 6 years of physician assistant. Really, there's a growing participation of private sector in medical education. Yes, and we need to look at that it is really effective, that they can really partner. And the realization that the public funds are never enough. There will never be enough public funds. So there's a need to look at. So when I talk about the private sector, it's not only how the COVID experience showed. It's not only private sector in health, but like the private companies. Leveraging on corporate social responsibility to improve capacity building. And they have really been involved a lot, increasingly, in supporting continual professional education. A lot of private providers have leveraged technology and have provided e-learning platforms that are being leveraged upon to provide continual professional development for health workers. What are some of the challenges? Lack of coordination of pre-service training. And this is what is resulting in the overproductions, because there is no linkage between the gaps and the training. So for the private providers in training and capacity building, it's about, the finances of it. I admit 100 students for nursing. I collect my money, I train them. What happened next is none of my business anyway. And that need to change with an involvement in the planning. Inadequate support from the government for the private health training school. That is a big problem. How does the government support and then leverage that support to ensure that the right things are done? And the private sector health staff are often left out of training on new and emerging issues. That is the in-service training. Most of the private level health workers working directly are left out, and this need to be addressed. And then the unclear roles of the private sector. As my colleagues showed, there are various sectors of the health sector, of the private sector in health. And we need to look at the roles for each of them. And there's no clear framework and governance structure by which the government or the public side is engaging the private sector. There have been talk about private sector chamber and all that. There need to be a framework. I think the private not-for-profit like CHAC has been able to establish a framework for engagement. But the other broad private sector, there's really the governance framework is not too clear. But there's a lot of hope in that. The private sector engagement work that WHO is doing can really provide support in setting up some of these framework. And from their work that they've done, it looked like Ghana has engaged them. Maybe Director PPME will be privy to that. It looks like there's some engagement with the WHO to try to see how this framework of this, they call it, the country connector of private sector in health is under WHO, and they are trying to facilitate private sector involvement in training and other things. So what are some of the things that we need to do? We need to look at the health labor market analysis involving the private sector, using evidence towards development long-term health workforce plan that involve the private sector who are also producing. And then also at the level of the in-service, private sector need to be involved in all new emerging training that are coming up. A system need to be set up to involve them. And we need also to look at approaches that we can do to sustain the improvement. We need to institutionalize training, get funding for training, foster leadership, maintain partnerships. And then, in conclusion, what I'll say is that capacity building and workforce development are very vital if we want to build a resilient and effective healthcare system. And the strategic efforts that will involve the private sector across multiple levels will ensure that Ghana will have the skilled workforce that is ready to meet the future challenges. So thank you very much.
Your smile will bring the sunshine day.
Thank you too very much, Professor Dr. Med Anthony Ofosu. Please let's give it up to him once again. All too soon, we are done with the first plenary session. At this point, we were supposed to have a musical interlude, but because of time, we'd quickly take two sponsors, tell us about their products, and then would proceed from there. So first of all, we'd like to welcome Unichem Ghana Limited to give us their presentation. Please let's give it up to them.
Please, you can do it better. You can do it better. So Unichem, we are watching the clock. Correct.
All right, good afternoon to you all. Oh, good afternoon to you all. All right, it's good to see you again. My name is Jude Yurinchi Asari. I'm with Unichem Ghana Limited. The top, Okay. I'm with Unichem Ghana Limited, pharmacist for Central Region. Today we are here as Unichem Ghana Limited to support your program. And as part of that, we want to take one of you to Dubai. Yes, we are serious about it. Last month at the pharmacist AGM, we took one pharmacist to Dubai. And then this month, we are taking one of you to Dubai. So I'm sure you have seen our questionnaires. If you have not seen it on your pages yet, you can pass by our stand. We are the first stand out there. We have a QR code there. You scan it. We have a few questions that are available. You answer them, and then you basically qualify to join our raffle. On Saturday at your dinner, we will announce the winner, and then, like we are saying, all expense paid trip, 3 nights and then 4 days in Dubai. All right. We want to talk to you about some of our products. We have this, one of our new drugs on the market called Diclolex Plus. All right. Please take me to the drug slide. It has 3 active ingredients. It has diclofenac sodium, potassium. Sorry, diclofenac sodium. Diclofenac and potassium as the active ingredient. All right. Normally, most of the diclofenac on the market has sodium as the salt, but we are using the potassium salt because it's faster when it comes to solution and onset of action. Then again, we have PMO 500 milligram and then cloxazone 250 milligram. So the PMO basically we know is an antipyretic, NSAID for the diclo, and then cloxazone is a centrally acting muscle relaxant. So the 3 of them coming together help you for better pain relieving effect. All right, so we at Unichem, one of the things or one of our hallmarks is quality. We don't compromise on our quality of our drugs for anything, not even the pricing. Sometimes out there they say our drugs are a bit expensive. We tell them that we put a lot into our drugs and then we expect the drugs to work in their maximum best. I mean, of what use is it after clocking your patient, you are done, you give a medication, patient goes and comes back and says it didn't work. Then cost 90, we are back to square one. So as part of that, this is how the drug is packaged, all right? It comes in a box like this of 10, and then it comes in a silver foil like this. Before the drugs come in patient packs like this. So we have put all these to ensure that by the time the drugs leave our factory to the end user, the bioavailability is 100%, because how the drugs are handled from us before it gets to wherever it's supposed to get to, we cannot assure how it's going to be handled. Some come into contact with direct sunlight, and then the silver foil is going to protect and prevent the drug from being degraded. And then also, if it comes in contact with water, it's not going to affect the drug. So we are telling you that this drug, we have put a lot in this drug to ensure that quality is achieved at the end of the day. All right. So we have put all this, and this is one of our cheapest drugs on the market. Who gets the price correctly? I'll give the person a whole box. How much do you think we are selling? How much do you think we are selling one of these? Or how much do you think you want to buy this for? After all I've said, 20 cedis, you have tried. 10 cities, no. 15, no. Sorry? 5 cities. Hey, auntie. But she's correct actually. Please give her 1 box for me. Give her a whole box. So we are giving you all this just for 5 Ghana cedi for a patient pack of 10 tablets. All right, please take me to the cough syrups. Go on. Yes. Yeah. So please try it for us. We believe in our medications. Next slide. All right, it's okay. We believe in our medication so much that we are saying that you try it for us. And then, who is having any form of pain here right now? I will give you some. No, we trust our product so much. Yes, you're having pain. Please help me here. Any other person? Okay, 1, 2, 3. My team will help distribute them. Please, some people are having pain, so please give us as many as are having the pain. It's okay, it's fine. Yes, please. If you're having any form of pain, you take it and then give us feedback. Our stands are there. We want you to trust the product before you use them. All right. We have, next slide, please. Next slide. Okay, we have another range that made us very popular. In the just ended Ghana Business Awards, we won the brand of the year for this particular range of product. These are our cough syrups. All right, these are our cough medications. And then they are so popular on the market. Next slide. Next slide, please. All right, so this is our Luex Baby on the market. I'm sure a lot of you have seen this drug before. Luex Baby has the glycerol as the active ingredient. The FDA of US is saying that glycerol is the safest the safest component for infants. All right, so if you are looking at giving some that is very safe for infants 4 months and above, we are recommending our Luex cough syrup for you. The glycerol basically soothes the throat, prevents harmful irritants like smoke and dust particles. Also helps a baby to be able to bring out the cough when the baby is in distress. All right, next slide. Next drug. All right, we also have our Luex Child Dry Cough Syrup. This is also made for children specifically. All right, it has dextromethorphan and then chlorpheniramine maleate as the active ingredient. So it is very effective for coughs that accompany colds and then flu. We are looking at 6 years and upwards. This is another choice of drug that we can give them. All right, next of the cough ranges. We have 6 of them in total. We have the children's chesty cough. This is for productive cough. We have ammonium chloride, chlorpheniramine maleate again, sodium citrate, and a menthol 1 milligram. All right. Also for our kit as well. So if you're looking for something that can help the productive cough of children, you are looking at Luex children chesty cough. Next cough, please. Okay. You also have guaifenesin, bromohexane, and phenylephrine 5 milligram. We are saying that this is effective for cough that accompany colds and then flu. It is powerful combination of it's an expectorant, a decongestant, and also a mucolytic agent. Next of the cough. We have our Luex adult dry cough as well. It has dextromethorphan and then menthol as well. Same again, we are looking at cough that are dry and then irritates. All right. It's also good for this one is specifically for adults. Please next. We have the Luex adult chesty cough and then the children cough. So the chesty, we have the child and then we have the adult. So we have grouped them into 2. We are saying that it is mucolytic for children and also adults. If anything, the cough is we want to break down the muco for them to come out. We are saying that these 2 active ingredients are there for runny nose, itchy nose, and itchy eyes and throat as well. The chlorpheniramine maleate is going to take care of it. Blocked nose in children and then also blocked nose in adults. These are the active ingredients handling it. Next slide, please. The adult chesty 2 and then child chesty. We are saying that for runny nose, for dry cough, blocked nose, and then throat irritation, it's also another good option for you. Next slide. The last on the cough list is the Luex nighttime cough. This was made specifically for adults and then children from 6 years and above. It's an expectorant, it's an anti-allergic drug, and also a decongestant. It's very effective 3-way action. So we are saying that there are 6 of our cough ranges, our lowest cough ranges on the market currently. All right. So if you are looking for a cough preparation for your client, we are saying that look no further, look for lowest range of cough preparations. Next slide. All right. So I'll end with this. This, I'm giving you free apple, is in one of our questions. All right. The lowest baby has only 1 active ingredient. The lowest child dry has 2 active ingredients. The adult dry has 2 active ingredients. The lowest adult chassis has 3 active ingredients. The lowest nighttime also has 3. And then the last one is the lowest child chassis cough. It has 4 active ingredients. I like that you are taking a picture. It's free apple I'm giving you. It is live and colored in the quiz. All right. So thank you so much for having us. We still remain one of your number 1 pharmaceutical companies looking out for you guys. Thank you so much.
Thank you very much, Unichem Ghana Limited. So we have next Dr. Selom Kutrati to give us a presentation on the human papillomavirus vaccination. Please let's give it up to her.
Hello, good afternoon. Please, can I get a pointer? Good afternoon. So I'm making this presentation, unfortunately, to an almost empty room because I see my colleagues are all outside. But I'm here to basically tell us where we came from, what we are doing now, and what we expect that as colleague doctors will do to improve the uptake of the human papillomavirus vaccine, HPV. So please don't let the 5 agenda items scare you. It's not quite, we're not doing a lot of talking. You see what we've done. A lot of pictures are in there as well. So I'll basically tell you where we started from with our background, the various pilots that we have done. I'll run you through briefly. I'll tell you what we did during our campaign in October. Then I'll also tell you what we saw and what we think we can do for it. And there's a slide for references because obviously this is an educated or highly educated group. So I can't just present to you without giving you references. So we all here know what cervical cancer is. And we know that it's the second most common cancer among women. And unfortunately, it's the one that also kills us quite a bit. Because in 2022, over 3,000 women were found to have cervical cancer, which are new cases. Unfortunately, about 1,815 of them died, which is quite a very high number because cervical cancer, when picked early, can actually be cured, more or less. We also know that cervical cancer is caused by persistent HPV. And typically the serotypes 16 and 18. There are other serotypes that also cause it, but about 71% of cases actually are caused by the 16 and 18 serotypes. And we also know that apart from causing cervical cancer, these serotypes also cause other types of cancers. So they cause anal cancer, also cause a lot of head and neck cancers as well, cancers of the vulva and the vagina as well. So HPV is not, in quote, a woman's virus. It's a virus that affects everybody. And we know from research that vaccines are effective. The vaccine we are using has been licensed for about 19 years now. We have 19 years worth of data to prove its effectiveness. We have data to back its safety as well. So we know that with vaccines, there's a lot we can do that will prevent our women or our girls from developing cervical cancer. So the vaccination is rooted in the WHO strategy to eliminate cervical cancer by 2030. Do we think it's achievable? Please, do we think it's achievable? Hey, I'm hearing yes, I'm hearing no's there. So there are 3 things that WHO says we should look at doing. We are starting with what I call the lowest hanging fruit, the vaccination. We are looking to immunize our girls, about 90% of the girls, 9 to 14 years. If we're able to do that, we know that we'll prevent them from developing HPV, persistent HPV and then cervical cancer. And for those of us who are currently out of that age range, we are looking at screening about 70% of us for HPV and also for cervical cancer. These tests include the VIA, they include the pap smear and others. And then for those who actually have the disease, we want to make sure that at least 90% of them have access to care. We know within our Ghana health system, of these three, I think the immunization will be the easiest to achieve, to be honest, because for screening, it's an individual decision. Just like breast screening, we make so much noise, but the woman has to take time out of her day and go and get screened. The screening is also not free, unless there's a program where some groups are doing. If it's not that, you have to take money from your pockets to go and do screening. So that's also a barrier. Then with the treatment, we have the issues of the numbers of clinicians that we have to take care of people with cervical cancer. The gynecologists, the oncologists, radio-oncologists, we don't have a large number. We don't have a large number of centers also taking care of cervical cancer. So of all these three, this is the easiest we can do, which is with the vaccination. So what have we done in the past? This cervical cancer vaccination or the nationwide rollout was rooted in work that has been done over a few years ago. So one study was done in 2013, and that used bivalent Civarex. That is the vaccine that has only 2 valent, that's 16 and 18 alone. And in that study, we did more of a school-based approach, and we looked at girls in class 4 and 5, and a few in class 3. And of all those, we were able to get 80% of the girls enrolled. And we use a 3-dose schedule. And as you can see with a 3-dose schedule, once you start, by the second dose, a number will drop out. It's a natural order of these things. By the third time, another number will get out. So if we start for 31,000, and when we're done, about 25,000 were the ones who ended up. So almost 6,000 of the girls did not complete the dose schedule. So that's a challenge that comes with using multi-dose schedule vaccines. Then another study was done, which was sponsored by Gavi, using Gardasil 4, which is what we are using currently. And this one was done in 2015, and it was done in Northern Region and in Greater Accra Region. And of this one, we also did the same school-based approach, but we used 2 arms. We used those who are doing 3-dose schedule and those who are doing a 2-dose schedule. And for those doing the 3-dose schedule, we had a population of about 7,000 for those in school, and out of school, just 272. Because we know that the girls around the eligible age, most of them will be in school. We have a few who are not in school, but most are in school. And for those, what we found was that, as you see, 7,000 of them started, 6,770 ended. So some dropped out again, as we would expect. And then for first dose, we had 6,000 for. By the second dose for those in 2-dose schedule, we have about 6,000 again. So about 400 also didn't complete. So what we found, if we do a multi-dose schedule, we'll definitely have dropouts occurring. And then another lesson we learned from this was that in Ghana, we have something we call class 1 mami, class 2 mami, people who are very old to be in the year group. Now, GES says we should have a right age for school. But if you go to my village, for instance, somebody will enter class 1 at 9 years. So if you are going to do this, by the time she gets to say the class 4 or class 5 that we are talking about, she's probably 18. Because she may repeat a number of times. If she's 18, unfortunately in Ghana, most of these girls are already sexually active. So we learned all these lessons and we decided that no, going forward, we'll adopt a different strategy if we want to do the nationwide rollout. So what did we decide to do? We did an age-based strategy. So for us, we are saying that girls aged 9 years will take the vaccine. And then we said that we're going to do in school, which was supposed to have been an opt-out, and then out of school girls. I'm saying it was supposed to be because that was the strategy. Unfortunately, when it got to the ground, it became a whole different thing. People started imposing, unlike what the law, the Public Health Act and the Children's Act says. Now we're doing consent forms, a whole lot took place, but this was our strategy going in. We also said we're going to do a single dose of the quadrivalent Gardasil. And we started with a campaign. We did a 5-day multi-age cohort campaign. We did 9 to 14 years. And we targeted about 2.2 million girls. And we did it across the whole country. And after the campaign, we've gone into what we call routine immunization. So we are looking at the same girls 9 years, but we are also going to do a catch-up for the 10 to 14 because we know that we're not able to immunize all of them during the campaign due to a lot of the misinformation that was circulating. And you ask yourself, why are we looking at this age group? Because that was a common question that was asked. Why 9 to 14? First of all, we found that at that age, they elicit a stronger immune response to the vaccine. We also found that a lot of them would not have been exposed to HPV. most of them will not have had sexual debut. So then we are targeting them just before they encounter the virus. And then thirdly, it's a good time for cost effectiveness because you want to give it at the best time where you have the maximum results. You also have evidence for the single dose schedule. So we didn't just decide that looking at how the dropout rate was, that was why we are doing single dose. A lot of work has been done by WHO and others. We have various studies that show the efficacy of a single dose compared to a 2 or 3 dose schedule. Because in countries like the US, they are still doing 3 dose, 2 dose, and the rest. But for us, for looking at the data that we've had across even lower middle income countries and low income countries, and even high income, 1 dose is enough if it's given at the right time, which is why we picked the time we did. And what we also found was that people talk about why aren't we immunizing the boys? Because HPV is not just cervical cancer. But for now, looking at the way the vaccine was introduced, it was targeted towards cervical cancer. But we know that if we immunize the girls, we're able to get about 80% of the girls immunized. The boys will automatically have a spillover immunization because most of those girls will end up having sexual intercourse with the boys. So if they're not being able to spread it, the pool of circulating HPV will actually reduce in the population, which is why we are not targeting boys to start with now. So these are just more evidence. I'm sure the slides will be shared and you can look at it and then read the studies if you are interested. So what happened with the campaign? We launched it on the 8th of October. Our minister was there. That was the first girl to receive the vaccine in Accra. Then we did an in-school campaign and then an out-of-school campaign. So you see my staff here, somebody in church, Makaranta, this was at Salaga Market. They went, anybody they found who was not immunized, spoke to the parents and immunized them. Based on that, we were able to immunize about 1.8 million girls, which was quite good. We thought we could do more, but of course, looking at what happened with the rollout, our performance was quite good because we're doing well. Then some media people started making noise, and then parents started withdrawing. But I'm sure the director is nodding because she knows what went on during the period of the campaign. There was a lot of work that had to be done extra to try and catch up with what we did. But we were able to do about 84.7%, which is quite good. Because remember I said, if we do 80%, even our boys are covered. So we have done, at least we have covered the boys in that population group. And across the various age cohorts, you realize it's approximately about the same coverage across. So we did quite well. There was nothing like just children, but everybody across was covered. And it was mostly in school. This is the in-school population. Most of those we immunized were in school, over 90% of them. And AEFIs, this was something that pre-campaign people were talking about. Are we going to give their children something to kill them? What we expected was what we found. Typical AEFIs were headache, abdominal pain, fever, pain at the site, swelling. Those were things that we thought would happen. And in fact, the 2 most common were headache and fever, which we were expecting. And luckily, we didn't have any serious AEFI or any mortality. So we're quite pleased with the rollout. So what did we see during the campaign? Misinformation. In fact, my phone was full of these messages. People were making videos, people were sending messages, or people were sharing all kinds of information, and you'll be there and you are receiving calls from your bosses. Have you seen what's happening? Somebody says this. There's a TV stroke radio presenter, for instance. There was a day he went on radio and my phone wouldn't stop ringing because people were saying, go and tune in. But you can't engage such people head on. You let them talk and then you try and, when you go on the radio or TV, you try and kind of roll back the things they have said. People were circulating videos and audios around. In fact, this particular link was being circulated by a doctor. That was what made it quite surprising because a medical doctor was spearheading misinformation. Up to now, the person is still spearheading misinformation. No amount of engagement would lead a person to stop. So for me, it's quite important that we all understand what we are doing because this is for us as a country. It's not for EPI program or not for pediatricians or obstetrician gynecologists. It's for all of us. I'm sure that if everybody is looking to their family or extended family, they may have known somebody who died from cervical cancer. My grandmother died from cervical cancer. The little I remember of it was quite a painful death. So I've seen what happens, and I know that if we work very hard, we will not have our children and grandchildren going through this anymore. And then we had the common circulating myths. You are trying to make our girls promiscuous. You want our girls to become infertile. Bill Gates is sponsoring you. They even said me, I've received billions of CDs to introduce a vaccine. And I asked them to please point me to where the billions are taken away, because it looks like somebody has chopped the billions in my account. There were a whole lot going on. And every time we had engagements, we would try and address them, because these things, since COVID came, misinformation has become a very big thing around vaccinations. And then private schools, I spoke about the consent forms. All of a sudden, they are saying that we want consent forms. Then the way they will even word the message to the parents will say no. They'll tell you, the people coming to vaccinate are there. Do you want us to vaccinate your children or not? And all it takes is one parent to say no. Then I was getting screenshots. One no, then all the rest will be no. The information we give them to share, they don't share the information. We also had issues with data entry by our staff. Some people will not even allow you to even enter their premises to immunize. So now we are camping at the entrance of the school. When the parents come in, we speak to you and we immunize, which is quite difficult because it's an injection. It's not like a drop that you can even drop. So it made a thing quite difficult. At least for us, we have a few good practices. In fact, there was a lot of leadership involvement in this exercise as compared to previous exercises. Director is here. She will tell you, DG was calling, Director of Public Health was calling directors, Zoom meetings, everywhere you see the directors on the ground working. There was also integrated information. We also used a lot of means to meet people. We were in webinars, we did online meetings, we went to community engagements, we went to radio, we went to TV. There were so many things we did to try and reach out to the people about the vaccine. And then also we had a lot of flexible delivery strategies. Like I said, if you say you allow us in your school, okay, fine. We'll just camp out and wait. When it's closing time, then we are waiting for the parents. Can we immunize your child? Then we go ahead and we immunize. We're able to adapt as things went along. So right now, we are on routinization. The vaccines are available in the public facilities. I know some regions have made flyers. We share them around. If you need a vaccine, you can walk in and get it. But there are also questions around, should we just leave it in routine? Because it's possible, I know if it's there, people won't go. There must be a time we are still thinking through. Are we going to be doing quarterly campaigns, yearly campaigns to try and mop up? Because some countries, South Africa for instance, once a year they do a campaign of a sort. Because they realize that the parents will never take their children. So we are looking at flexible strategies around that. And then we're also looking at the role of doctors. Because we are trusted people in the community. Because if we lead the advocacy, parents will take it up. In your churches, in your social groups, in your mosque, wherever it is, if you take the time and even get 10 minutes to tell the parents about this, it goes a long way to engender trust in the system. So what should we do as doctors? All of us here, we are trusted. Anytime they open your mouth and they ask you, or you speak on a topic, people take it as the law. They don't even bother to go and do any research. So we are supposed to provide clear, accurate, and empathic counseling. So when people come to you, we shouldn't just, this one, just go and take it. We have to explain to them why. We have to dispel the myths and also respond to concerns about side effects. And then also, we should reinforce the fact that the vaccine is available as part of routine child protection. And it's not a new vaccine, and it's not an experiment. We've used it in the country since 2013, so it's not new. And there are people I know here whose children have taken the vaccine in the private sector, like we are saying, public-private sector in the healthcare. They've taken it there, and even their boys have been given the vaccine. So it's not a new thing. So it's important that we lend ourselves as ambassadors for this, so that in the next generation, we will not have cervical cancer the way it is now. So I told you I have plenty references for you. And these are our partners. You can see GMA prominently here. GMA has really supported us through this exercise, and we are really grateful for this platform. We also have WHO here, who also led us to come here to come and speak to you today. Thank you very much.
So as doctors, we all have to assist to dispel the vaccine hesitancy problem. Unfortunately, these days you actually hear and see doctors actually leading the charge, some even organizing some sessions and putting out certain beliefs, unproven scientific facts as well. So please, we have a charge to keep. And we are aware that Medical and Dental Council is beginning to look into some of these issues because it's beginning to cause problems. And you know our people, once they hear an information, it's a doctor who said it. You know, doctor the catcher me, and everything else you say will not be heard again. Thank you, Dr. Akuchuati, and thank you, WHO. Please, WHO needs to fill some sheets to show that truly this presentation was given and we heard them. So a form is going around. I know you've already filled the attendance forms for the CPDs and all that, but the form will be taken care of as well. Thank you. Please, there's, I don't know, how do you people call this thing? It's a water bottle, a very stylish water bottle. Please, somebody left it at one of the venues yesterday, and kindly come for your water bottle before I begin to use it. Thank you.
Thank you. So up next, we have a final presentation by one of our sponsors while we get ready for the panel discussion that would start off the second plenary session. So I'd like to call on Way Lead to please give us their presentation. Please let's give it up to them as they come.
Thank you very much. My name is Sian Sefen Soku from Way Lead Ghana Company Limited. And I want to say thank you for the opportunity and good afternoon to all our doctors here. Good afternoon. I'll be very brief, please. So in this presentation, I'm going to talk about us, our community, and we have some printers also available. After that, we will make room for questions if there are some. Way Lead Company Ghana Limited has been in the country since 2012. We have our offices in Shanghai in China, California in the USA, and also here in Ghana. We are stationed at Sakumono. Our first development is Vista Del Mar. It's a 22-unit home with a clubhouse, a swimming pool, a gym, and then a rooftop. These are all 4 bedrooms located at East Airport or Chado. This is completed and sold out. That's our first project. The second one is Les Jardins Symphonique, 52-unit homes, 3 bedrooms, 4 bedrooms, and 5 bedrooms, located at Sakumono. This is also 100% sold. Location of this is Sakumono. This is the current view of Les Jardins Symphonique. You see the asphalt and the rooms, the houses with the roof, everything perfectly built. Location is Sakumono. From where we are, 30 minutes you get to East Legon. Nungwa is 10 minutes. Tema, from where we are to Tema Harbor is just 10 minutes, and then 25 minutes to airport. So the project, as I said earlier, is located at Sakumono, and the land we are developing is almost 50-acre land, mixed property. We have the apartments, we have some for the townhomes, and recently we have also introduced one that is going to have shops. We're going to have a gym, we're going to have a police station, and all the amenities in there. It is a litigation-free land. The land belongs to Ghana Post, so it's a joint venture between Way Lead and Ghana Post. So if you are buying a property from us, know that no one is going to bother you that live where you are, because this is a government land and it has no litigation at all. So this is our Alphabet City, which is, all of these are apartments. You have 2 bedrooms, you have 3 bedrooms. The 2 bedrooms are of 2 types and the 3 bedrooms are of 3 types. The amenities in here, we are talking about a swimming pool. You have a summer hut, children's playground. There is a basketball court, tennis court, and then a place to sit, and relax, the green areas and all. This is also located on the same piece of land, 48 acre, and also located at Sakumono. These ones are all apartments. This is a pictorial view of the place. It's a gated community, of course. You have a paved road fitness center, and then the amenities, as I mentioned earlier. This is the current state of Alphabet City. What you are seeing is not a 3D picture. This is built. What you are seeing is the real picture of the buildings in there. So you're seeing the apartments. Now you see the children's playground, the summer hut, and then the pool over there as well. These are some of the pictures for the interior decoration. You have the living area, you have kids playing around, that's a dining, and then the road is also neatly paved. The kitchen is in there. You have the living area as well, as we are seeing from the picture. Now this is the block plan of the new development that we have started, also in Alphabet City. I will explode it, and then we will see the various types. This is what we call B1. It's a 2-bedroom that comes with a fitted kitchen, and it's open. You have the living and then the dining area together. 1 bedroom has its washroom inside and suite, and then you have the other bedroom having the washroom outside so visitors can have access to it. And this is 110 meters square for the 2-bedroom. This is a 3-bedroom here with its washroom, as we can see from the picture. This is another 3-bedroom. This is slightly built over the first one, where we have added a maid's quarter to this. So you can see from the picture. This is also a 2-bedroom that has been expanded, just like the first one that I showed you, the 110 meters square. And these are the prices, and of course we can do the city equivalents of the prices. And this is our new project that we call the Willow Lane, first of its type, where you have 4 bedrooms, 2-story. You have the ground floor, first floor, and then the second floor, and each unit is coming with its own elevator. So if you are buying this property, you don't have to think of buying another property again when you are old, that you cannot climb the stairs again. No, you have an elevator in there to take you to your master's bedroom. And this, we have first developed the 30 units in there. In all total, we are looking at building 103 units for Willow Lane. I will show you the types that we have in there. This is the type A of Willow Lane, 2-story ground floor. That encompasses, you have the living, the dining, the kitchen, and you also have a guest room, and of course the place where you have your kitchen. This is the plan for the ground floor, the first and then the second. This is the type B, and this is also the plan for type B. This is the current state of Willow Lane. This is the current state of Willow Lane. And these are the prices. Of course, we can do the city equivalents of the prices as we see here. This is also a new one that we have brought into the market. We just started construction of this last week. We call this the Daffodil Alley. It's also apartments where we have shopping mall, gym, pharmacy, studio apartments, 2 types of 1-bedroom apartment. You have 2 types of the 2 bedrooms as well. And then you have a 3-bedroom, and you have also a double-run elevator in the block. I will explode this now. This is, on the left, you have a studio. On the right is a 1-bed. This is also a 1-bed. This is a 2-bedroom apartment in the Daffodil Alley. This is a 3-bedroom. And these are the prices, starting from 38,100. You do the city equivalents, and then you get a studio apartment in Daffodil Alley. Then, I'm coming to the last one. These are semi-detached property. You can see on the left. This is it. These are the 3D impressions. When we are done, this is exactly how they are going to look like. And this is the plan for the semi-detached. So on the left, far left, you have the ground floor for the semi-detached. In the middle is the first floor. And then on the right is our rooftop, where you can come, you climb up, and then you sit on the rooftop. You enjoy the view of the ocean and all. And this is the price for the semi-detached. Just as I said for all the others, you can do the city equivalents as well. For our payment terms, we require that you make initial deposit of 20%, and then the balance we spread for you for 2 years without interest. There are mortgage options as well, and you can buy individually, or if we have a number of you coming together to buy as a group, then we are going to offer you more discounts. And also, there is a referral package. When you refer anyone, maybe a family abroad, or you have a friend who wants to buy a property, and you refer them to us, there is a referral package that we are going to give to you. Lastly, we also have some printers that we have available to talk about to our doctors here. The first on the left is a label printer that prints the label for the wrist, and then you have a card printer as well, and then we also have the printer that we can print our x-rays on. And with this, we are going to supply, for anyone that is interested in getting the printers, we also supply the consumables, and it's under 12 months warranty, and we also do the maintenance for you within the warranty period. Thank you very much for having me. If there are any questions, please, available.
Thank you, Walid. A lot of questions will come to you at your stand. So we get your men and women there ready to respond. Let me say that this program is being live streamed on all the socials of TV3 and their partner stations. And we have a lot of viewers online also listening in. And also thanking TV3 for coming in to do this for us as our partner. We have heard the presentations. We have questions to ask. And so we'll zoom in straight to the panel discussion. And this will be moderated by one of our own, a female. That makes me another female, and so I'm a gender advocate now, a strong one. She is Dr. Med Alberta Ajeben Brichum Nyako. I hope I got it correct. Thank you. She is a public health specialist and has been doing this for so long, from Kumasi Metro Director, moved on to become Regional Director for Eastern Region, then moved on to headquarters to become the Director, Policy, Planning, Monitoring and Evaluation Division, and then now has decided to shine her light in Central Region as the Regional Director. Please, let's welcome her with a big round of applause. And joining her on stage will be all our distinguished speakers, and then Dr. Kuchuati will also join her to respond to any concerns you have about the HPV vaccines. Please, let's welcome them once again.
Good afternoon, distinguished ladies and gentlemen, and welcome back to our panel discussion this afternoon. The theme for this AGM, strengthening private-public partnerships for sustainable healthcare delivery, is not merely an academic topic. It is an urgent operational necessity. And I think we all agree that we can no longer continue the traditional model or the old way, where these two systems, private and public, operate in silos. That option is no longer viable. We stand at a critical juncture where the only path forward is one of a shared commitment and synergy. We must recognize that the public and private domains are not competitors, but rather complementary in securing our nation's health now and in the future. We thank very much Dr. Maxwell Entry for his presentation on innovative financing for primary health care, for health service delivery and its sustainability. We also thank Dr. Belinda Efriye Nimako for helping us to understand how we can expand our coverage for universal health and also leveraging public-private partnerships in that regard. And also Professor Anthony Adolfo Ofosu, who also talked to us about capacity building and health workforce development. So I shall start. I would only limit my question to one per panelist so that you can also ask questions and then we shall be done. I will start from my immediate right, Professor Anthony Ofosu. You've shared beautiful insights on capacity building and workforce development. Now, we are in an era of much difficulty with the attraction and retention of doctors, with its ensuing maldistribution across the country. What are some of the ways to address this challenge through public-private partnerships towards the achievement of universal health coverage?
Okay, thank you very much. Let me look at, yes. So the issue of maldistribution, I think it hinges on a lot of factors. One is the social amenities available in those places, like the school, and most of the time these are young people, either nurses or they are very young people, they have young family. So then their unwillingness to move is sometimes driven by this lack of social amenities. So that's one of the things. And then also the fear of the unknown is something that we've seen, that when people do not know a place, when you mention it, is like, somewhere on Mars. So there's fear of the unknown that catches them. You say, go to Rara. This is somebody who has been born in Accra and all that. It evokes a fear, and that also brings hesitation. And then also, the whole issue of the government as the main employer is also one of the issues that drives. And then also, the lack of any pull factor, like incentives, is also one of the key things that prevent people from moving. So what I'll say is, how do we get the private sector to get involved in addressing this? There's a need to look at providing incentives for private providers to site in some of these places, like the way it was done for CHAG in the past, so that the government can use its leverage and power for taxes, provide tax breaks, provide equipment, for example, provide human resources that will move some of these private providers into these areas, and then they will use their leverage to get staff. By way with the government support also. That's also one of the ways, the similar model to what CHAG did in the past can also be looked at. And then the private training schools can also be a help, in the sense that instead of we sending these students to Cuba and Ukraine and all those things that government is sponsoring, why not identify people from these areas and place them in private facilities, of course, because then there's availability of space. In most of the public universities now, it is choked. The medical schools and things are choked. So then why not leverage and use the private facilities? And then instead of sending these people to China and those places and Cuba, and they come and they write the exams and now they don't pass, and now we want to use political influence to get them to, let's get them, and then the private sector get involved in that, in the training, and then we can get people into this area, because then the proviso is that you are being trained to go to that area, and the private sector is involved in that. And then we can look at the private, like companies, like we did in the COVID period. Companies as corporate social responsibility, picking up some of these issues, like the deprived areas, supporting incentive for doctors to be there as part of their corporate social. Let's say I'm a factory in a region, I identify and it should translate into some tax breaks for these private companies who are doing this. supporting, move, and providing incentives in some of them. And I quite remember in my other life, when I was a young medical officer, there was a timber company in where I was posted who used to give us annual bonus. I mean, yes, it was a timber company, and they used to give annual bonus as an incentive for health workers. Well, and this can be a model that private sector can be involved in. And then let's say like the vehicle hire purchase. Companies doing vehicles can be giving tax waivers to provide incentive for people like vehicles, people working in the deprived areas. And that's something that can be looked at, for example. And then we can look at the other sector like education. Because one of the key things is education for the children of those who are posted. So, I mean, getting private sector to set up, and in the past, Achempon did it in the what they call experimental schools in the regions to try to get civil servants, high caliber to come to the regions. It can be done supporting private sector to set up model schools in some of the deprived areas, so that I know that if I go there as a young doctor with my wife, my children, or if I go there with my husband, my children can get reasonably good school to attend. And the private sector can be incentivized to provide these schools in these areas, giving support in a way from government incentive. And then housing. Housing is also one of the biggest problems in some of these areas. But we are the health sector, we have land. So why not use the land and leverage it as BOT with private estate developers, and then get very decent accommodations for health workers who will be then sent to this. So I think basically off my head, these are some of the things that I think that the private sector can be used to leverage and improve the distribution. Above all, the critical thing is the policy to address maldistribution. There need to be a targeted policy that looks at the pull factors and the push factors, and try to, through within the policy, try to leverage some carrot and stick approach to push people. I think a start has come with this advertisement for positions in this area, and I think it's a good start. Declare vacancies, advertise, and let people apply out of their own volition. The next step is that then add incentives to these areas, so that I know that I'm working there for 3 years, but with it I'll come out with a double salary or something. And I think that would be a good thing to do. Thank you.
Thank you very much. Yes, I think he deserves an applause. Thank you very much, Prof. Adolfo. We really need the policy guidelines. We also need the incentives. I would go to Dr. Belinda Nimako, who also shared insights about expansion of UHC and the role of public-private partnership. So what I'm asking Dr. Nimako is, what does success look to you in a PPP arrangement beyond the expansion of the coverage rate? And I'm talking in terms of outcomes related to equity.
Thank you, Director. Well, for me, success primarily would look what it would look like is when we've been able to optimize the potential in private participation in our health sector. And with that, my focus primarily is around IT, because as you can see from all our presentations, whether it's the investments, whether it's in health workforce development, as we look into the future, training people, continuous professional development, it's all going to hinge heavily on our ability and our uptake of technology. And perhaps that is the area that we're a bit behind. So if we are able to flesh out the uptake of technology, which we also know that it would be heavily driven by the private sector and not the public sector, it means that we are getting to the last mile. But ultimately, in terms of how healthy are our people, that is our UAC coverage index inching as close to 100 as possible. And what that would mean is everybody at every corner of Ghana is getting the requisite set of services that we all need to live as long as possible. And that's success. Thank you.
Thank you very much. Yes, she also deserves an applause. My next question for Dr. Maxwell Entry. You've talked about the fact that we must move beyond traditional funding structures towards models that are based on value and outcome. So my question is, for a private healthcare provider, what is the biggest challenge they would have in moving from the traditional fee-for-service to this value-based or outcome system? They definitely would bear a risk. How would we minimize that risk so that they would want to venture? Thank you.
No, thank you. The beauty of this is that we didn't have the questions up front. So you are able to give very generic but also contextualized responses. So in 2022, there's a group think tank called McKinsey. And when Director PPME was giving their presentation, he mentioned about the lack of group think tanks for health. But there's one called McKinsey, and they did what they call what the future of healthcare in Africa would look like in the next 20 years. And they presented it at the World Economic Forum in Davos. And one of the key recommendations from that relates to the question was that the future of healthcare in Africa will be what we call the hybrid model. So if you look at the way we have evolved on mobile money in Africa, when you go to Europe, they don't have the same penetration of mobile money. And that's because we were so desperate with financial inclusion that we didn't have to go through the models that the West went through, but they call it leapfrog. So we leapt like a frog, and we did what we are doing now because it was driven by a need. I have served on the UHC 2030 advisory group for 2 terms. And we can all encourage ourselves that we'll achieve UHC 2030. The truth is that we will not. The truth is that we will not. Why will we not achieve UHC 2030? Because we have used the same delivery model that did not achieve alma mater to attempt at achieving UHC 2030. If you look at our service coverage index and you look at our out-of-pocket protection index, a lot of countries have totally gone back. In Ghana, we have made progress, but a lot of countries have gone back. Specifically in Ghana, there's a model as to how we can achieve it if we make the right choices within the next 3-4 years. Those discussions are not on the table now, and so we are not likely to achieve it. Currently, what the team is doing now, the UHC 2030, is to redesign the next milestone for the whole world. So we may come up with UHC 2050 or call it some other name. However, it is not all lost. And there are things we can do to make the smarter use of the money that we have. For some of us who work across sub-Saharan Africa and also in India, is when you come back home that you treasure what we have. The national health insurance that we have, that we take for granted, is a game changer. In the whole of sub-Saharan Africa, we are number 2. We are only second to Rwanda. If you take the whole of Africa, we are number 4. It's Algeria and Morocco, Rwanda and Ghana. We are the only ones who are doing anything 20% and above in terms of population coverage. All the rest are in the 5s and 10s and single digits. So it gives us an opportunity to use the money better. We have had the new administration uncap the NHIS, and it has released monies that Dr. Morrison's time they didn't have. Now the money is flowing into the system. But more money, if you look at the evolution of human development, more money does not solve problems. We did not discover penicillin by more money. The electricity was not discovered because of more money was available. So more money per se does not bring a leapfrogging. What changes the system is to stop building bigger candles and discover electricity is to stop breeding stronger horses and discover the steam engine. This is what our forebears did. So the same resources, how can we use it differently? And that's why the concept of value-based care is being promoted across the globe. That to really reach our milestone, we need a hybrid of virtual and in-person care. Otherwise, the current traditional model will not get us there. That's number one. Number two, we need to pay differently. And I've used the example of the taxi, the Uber. Currently, we pay when people sit in the car. We don't pay when they get to the destination. We pay for utilization, but we don't pay for outcomes, which is the destination, the reason why the person sat in the car. And we need to change that model, because if we start paying, yes, let's pay for the passenger sitting in the car, but let's also incentivize for clinical outcomes. And if we do that, we will have less people needing to sit in the car, and eventually our health bill will go down. What will happen is that there will be an initial spike in the health costs because you are topping it up with clinical outcomes. But if you look at it, and that's the work that was done at the World Economic Forum by McKinsey, if you look at it over a 10-year period, you see your health bill going down because you are being more efficient, and you see your clinical outcomes going up because you are being more efficient. If you track, this is my last one, if you track our clinical outcomes, let's take maternal mortality. Since the implementation of NHIS, which really shifted it, we have actually stagnated. Which means that doing the same thing will get us the same results. We will not reduce maternal mortality by doing the same thing. I am an obstetrician, by doing the same thing that Dr. Yeboah and I were taught and we have been practicing. It will not get us there. We need to change the model. And that's what value-based care is about. It's not new. Most other industries use it, but in healthcare, it's new for us. And that's really the game changer going forward. Thank you.
Thank you very much, Dr. Entry, for expatiating on the game changer. Please, let's give it up for him. You remember Dr. Selom Kutuati is not necessarily part of the panel, but she's told us that she needs us to be advocates. She's also asked the question about, should we routinize HPV vaccination or we should have deliberate campaigns? All these are questions that she also needs your inputs on. So you can ask questions also about the HPV vaccination. So ladies and gentlemen, the floor is open for questions for our three panelists, Professor Adolfo Ofosu, Dr. Belinda Nimako, and Dr. Maxwell Entry. You can please raise your hand.
Please, questions from us.
There's a hand.
Okay,
in the
thank
middle.
you. Ladies first.
Okay, thank you very much. My name is Dr. Safako Komegbe from the Volta region. My question goes to Professor Adolfo. My question is, we have very beautiful plans and policies on how to attract doctors, retain them, and send them to deprived areas. What is actually preventing its implementation? Because we have a lot of literature, we know what we should do. What is actually preventing it? And can Ghana actually achieve equity distribution of doctors in deprived areas? Or we should just assume that it's a political talk and go by it? Thank you.
Thank you very much. Can we have another question? Yes, the
Any
gentleman
questions?
in the aisle.
Okay.
So, good afternoon. I'm happy this topic is being discussed, and congratulations and well done to all the presenters. My name is Anesiok. So, it ties in with one of my manifesto promises I'll be reiterating this afternoon. How to get doctors to the deprived area. So, it sits within the bigger question that you are discussing about PPPs. You know, we know that Agenda 111 hospitals, for instance, are lying fallow. A lot of them at different stages. So is it possible, and that's what I propose, that can we get and encourage people to set up in deprived areas and then give them some tax incentives, so then it doesn't become the burden of government to put in the initial capital. In this way, you are putting money in the pockets of doctors, yet retaining care to the vulnerable in society. Thank you.
Thank you very much, Dr. York, for that question. So, Professor Adolfo, you have 2 questions to answer.
Please, we'll take one more and then the panel.
Okay.
Thank you.
Okay, I'm Kodia. So, my question also goes to Prof. I just want to add, recently the minister made a concern about posting 80% of the people in the current batch to deprived areas. I just want to know his viewpoint on that, because it came with a lot of backlash or a lot of repulsiveness from some people. Because you see, we are talking about distribution, but it's not just distribution, because a large chunk of these people who are going to these areas are going to end up sending about 60% of cases they can manage back to Kolebu, back to Konfanoche, back to all these people. So if you shunt everybody there, you leave the few people now to come and then handle all the cases that the people who left saw and they couldn't see, and then they sent back to Kolebu. So if 100 people were in Kolebu, seeing let's say 1,000 patients, now they are 50, but they are still going to see 1,000 patients, because the problem there is still the same. But I get the distribution. I just want his viewpoint on the recent decision to send 80% of people across, if we are doing it at the right time, or if it aligns with the policy that he's talking about. Then my second question goes to, I'm sorry, I've forgotten the name. On the HPV, I wanted to know, you talked about people's repulsiveness to the vaccine. I wanted to know if you've tried religious bodies, like churches, the Muslim communities, trying to get people on board. Thank you.
Thank you very much. So people seeing cases they could not see and sending back and all that is in between. We go to Professor Anthony Adolfo.
Okay, thank you very much. The issue of maldistribution, as I said, we have danced around the issue. The political will is not there. I mean, that's the reality. I mean, I have been someone who have worked from the grassroots and worked at very remote area that you cannot imagine. You see, and the solutions are clear. And I've mentioned some of them. The social factor need to be addressed. One of the ways of addressing the social factors, and we've discussed it in the past, but that one too, there appear to be no leverage to it, but I think that one with the private sector involvement can be useful. It's this agency model thing, whereas a private sector will employ specialists, maybe retired people himself, and then use them on short-term basis in some of the deprived areas. That is a model that is possible to do and that have been floated around for a long time. One of the things that we did when I was a DDG was reprofiling the deprived to hone it down from region to districts. Formerly, it was only region deprived. But we saw that it was not really true, because if you say northern region is deprived, somebody in Tamale and somebody in Greater Accra in some community in Adan East, then you are not being fair. So then we home down to district. The next thing is gathering enough data to home down to communities. Then it makes it easier. Then we can then move. So then we've canceled initiative then. We brought in 2 types of incentive. The incentive that we can control. This is the non-financial incentive. Promotion out of 10. I mean, getting to go to school out of 10. Those things are administratively possible to do. But then when it comes to the crux of the matter, which is the financial incentive, which everybody knows that is the ultimate thing to do. That somebody working in KJG, Kojokrum, should not earn the same as somebody sitting in the comfort of Kaneshi Polyclinic. It is not fair. We need to change that. But unfortunately, when you start doing that, the way our salary structure is and centrally controlled, it makes it very difficult to do that in a centrally controlled salary structure system, unless you decentralize it and send the money somehow to the place, so that the money is maybe routed through the local government or something. We need to look at some mechanism of doing it, because ultimately, when we started to discuss it, the Ministry of Health said they would do it. But for 3 or 4 years that our DDG, we never saw any progress. I mean, and they said it is with Ministry of Finance till date. So you are rightly saying it, that we know what to do, but the politics of doing it is where we are challenged. Other health workers will start mumbling, we are also in deprived areas, give us some. But you need to identify the critical skill that you need and incentivize the critical skills. That is important. With what Prof. York raised, I think I mentioned it in my presentation, that's also another way of looking at it. Leveraging private sector the way CHAG was leveraged, because as I said, there's not enough funding and fiscal space for the government to ensure access. And as my colleague said, if we continue to do the business as we are doing it, we'll never achieve UAC. But then we need to look at different models. So for example, as I said, why don't we incentivize the private sector, tax waivers, equipment provision, and all that? Some of this, and let them go there. Then they can pick up, and it expands the employment space also. And then on the question of whether we will ever achieve equity, technology does provide us with a leeway to do that. And that's what my colleague was talking about, leapfrogging. With telemedicine now, we can leverage it and ensure that somebody sitting in very remote area can still have access to specialist care. And that's something that going forward we need to try to do. How do we leverage the technology to facilitate access to quality care with the human being not being physically present there? And it's going to be very possible. It's just investment in the infrastructure. Investment in the infrastructure that is needed. And that is where also the private sector comes in terms of equipment placement and all that. I always say that the way we manage equipment in the health sector doesn't make business sense. And we need to move away from that. How does the government provide CT scan for a facility? The facility runs the CT scan, collects money from clients. CT scan breaks down 5 years. It cannot be fixed. And the government need to come and retool facility. It is never sustainable. How do we leverage private providers to place equipment, manage the equipment, and ensure that there's access to the equipment? Those are models that we need to look at. And I think leveraging on private sector can help us address some of the issues, and leveraging on technology can address some of the issues that we are facing. Thank you.
Thank you very much, Professor Fosu. We move to Dr. Selom Kutuati.
Thank you very much for that question. So yes, we did engage various groups. We went to the office of the chief imam. There was a group, Muslim women teachers. They also had quite a lot of work, which is why you saw a picture of the Makaranta. They worked through their networks and got us in there. We spoke to the Catholic Bishops' Conference. UNICEF organized a breakfast meeting for religious leaders across charismatic, Pentecostal, etc. But the challenge is that there is only a limit that the national level can do. There are so many churches or religious groups that don't belong to any group. And those are the groups that we expect that our people would go in to speak with. Even as doctors, there are a lot of us who belong to groups that don't belong to these broad groupings. And also the challenge too is that, what if the leader of the group comes for this meeting, we share the information. There's no guarantee that that information would go down to the individual members, which is why we are here today to solicit for our support, because our religious leaders are trusted, yes, but we are also a very well-known or well-trusted source of information. So if we are armed with the right information and the population comes to us, we can give them the information. We can also go to our various religious groups and ask them for a few minutes during